तो आज का हमारा टॉपिक है एंटी HIV ड्रग्स। तो इसका जो ओवरव्यू है हम देखेंगे ड्रग थेरापी, ट्रीटमेंट एंड प्रोफाइलैक्सिस इन एडल्ट, प्रेग्नेंट वुमन, न्यूबॉर्न एंड HIV विथ TB मैनेजमेंट, क्लासिफिकेशन ऑफ वेरियस ड्रग्स जो HIV में यूज होगी, ड्रग ओवरव्यू। हियर इज द अपना इंट्रोडक्शन। HIV वायरस is the type of RNA virus, retrovirus. Why it is called retrovirus? Because it uses the DNA polymerase, also known as a reverse transcriptase, which is the RNA dependent. That's why it is called the reverse transcriptase, RNA dependent DNA polymerase. HIV virus origin in the 1930s. ये माना गया कि ये चिंपांजी से ह्यूमन में आया, but there is exact origin is unknown. First case detected in USA in 1981 in young homosexuals. Transmission, there is various 4 types mainly, various routes of transmission: unprotected sexual intercourse, blood transfusion, parent to child transmission, and infected instrumental injury. Most common mode of transmission is the unprotected sexual intercourse. Here you see the figure that HIV kiss से, touching the hands, मॉस्किटो बाइट से, फूड एंड ड्रिंक से, एयर वाटर से, टॉयलेट बाथरूम से यूज करने से, शेयरिंग करने से ट्रांसमिट नहीं होता है। ट्रांसमिशन बाय दिस रूट्स विदाउट इंटरकोर्स, विदाउट बैरियर यू इंटरकोर्स, अनप्रोटेक्टेड सेक्सुअल इंटरकोर्स, प्रेग्नेंट वुमन, मदर टू चाइल्ड ट्रांसमिशन, ब्लड ट्रांसफ्यूजन एंड वेरियस इंस्ट्रूमेंटल इंजरीज, नॉन स्टेरॉइड इंस्ट्रूमेंटल इंजरीज। हाई रिस्क पॉपुलेशन कौन सी है? कि फीमेल सेक्स वर्कर्स, MSM, IV drug abusers, transgenders are at the high risk. Now the process of infection to the host divided into the multiple stages. First stage is the binding, second is the fusion, third is the reverse transcription, fourth is the integration, fifth is the replication, sixth is the assembly formation, and seventh is the budding of the virus. Here you see the various drugs which act on the various stage of the infection to the host, during process of the infection to the host. For the first stage binding, during that chemokine co-receptor antagonist, CCR5, post attachment inhibitors, just remember the name as of. Second is the fusion inhibitors which act on the fusion stage. Third is the reverse transcription. Here the classical drugs like nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors act on this stage. On the first stage there is the integrase inhibitors which act on the integration part, fifth and sixth part, and here the seventh part, protease inhibitors act on the budding parts. Further shown in this figure आप देख सकते हैं कि फर्स्ट वायरस की एंट्री हो रही है, Here you see virus attached to the host cell CD4 T cell via the help of the chemokine co-receptor, which is the CCR5 and CXCR4. On the virus surface, there is a two type of receptor, GP120 and GP41, two type of the proteins which bind with this chemokine co-receptor. HIV has the single-stranded RNA inside. Here you see the various enzymes in the core, like a reverse transcriptase, integrase, and protease, which use in the further stage of the infection. Now the virus is attached to the cell surface via the help of the fusion protein and chemokine co-receptors. After that, there is the entry of the whole virus and particles and core into the cell. Here the drug act is the fusion inhibitors act on this stage. Drugs including fusion inhibitors we study in the next slide. The enfuvirtide. After that, entering into the cell, the virus is use the reverse transcriptase enzyme and form the proviral DNA by the help of the enzyme reverse transcriptase. Here the drug act is the reverse transcriptase inhibitors. That includes our classical drugs, nucleoside reverse transcriptase inhibitors and non-nucleoside reverse transcriptase inhibitors. Now the further proviral DNA form is integrated into the host DNA by the help of enzyme integrase and formation of viral and host DNA mix-up. That is a mixed DNA, the host and virus. Now the virus use the host DNA and process of transcription and translation taken place. After the process of the transcription and translation, there is a viral budding by the use of newly formed viral proteins. Formation of immature virions and there is a mature virions. Here the drug act is the protease inhibitors. It include lopinavir, ritonavir, indinavir, saquinavir, like that. Now formed HIV virus is released into the circulation and same process repeat again. Infect the another CD4 plus T cells and same whole cycle repeats again and again and infection proceed ahead. So the HIV virus infection is the permanent, but it cannot be cured. Only we can do is the either reduce the virus entry, replication into the host, prevent transmission to the other persons, and improve the survival. Clinical course, yeah. Next slides we study. Clinical course. Here the first primary infection to the host, point of primary infection. First phase is the acute phase. Here you see from the second week to 9 weeks up to is variable to the person to person. Acute phase. Here you see the symptoms in the person who are infected. After that, there is a clinical latency phase. During this phase, there is a person remain asymptomatic. Person may remain asymptomatic or very mild symptoms during this phase. Clinical latency. Here you see the CD4 plus T cell count is decreasing in acute phase, then increasing further in clinical latency phase slightly. Afterward, that decline, gradual decline is there. And the last phase, after 8 years or further, there is a full-blown AIDS, acquired immunodeficiency syndrome. Here, CD4 plus count may decrease from 400 to 200, and during that, there is opportunistic infections like toxoplasmosis, Kaposi sarcomas, cervical cancer, which occur at this stage. Here you see same in the tabular form, acute HIV infection, 2 to 4 weeks. Here flu-like symptoms, myalgia, arthralgia, rash, lymphadenopathy, sore throat, fever. During this phase, there is a high level of virus in the blood. CD4 plus count may be normal or slightly decreased. During this phase, standard assay is the P24 assay in HIV RNA test. Chronic phase, chronic HIV infections may last for the years, 6 to 10 years without treatment, and this phase remain asymptomatic mostly or with mild symptoms. Viral load may remain stable mostly in this phase, and CD4 plus count gradually decline over the time. Symptomatic HIV infection after several years, there is oral candidiasis, chronic diarrhea, night sweats, weight loss, fever. Afterward, full-blown AIDS will be developed and CD4 plus count fall below 200 cells per microliter when opportunistic infection or AIDS defining condition is common, like pneumocystis carinii pneumonia, tuberculosis, Kaposi sarcoma, toxoplasmosis are the common during this phase. CD4 plus count below 200 cell per cubic mm. Investigations for HIV is primarily focusing on the diagnostic of infection. Diagnostic testing we already seen. In HIV antibody testing, ELISA and Western blot, which detect the antibodies to HIV. We already discussed about the P24 antigen assay, which is identify the early infection. That is main thing during the acute phase. Another is the RNA PCR test, polymerase chain reaction during acute HIV infection. This both is helpful in the acute infection of the HIV HIV RNA and HIV RNA PCR and P24 antigen assay. Another is the first generation combination test. Here you see both HIV antibodies and P24 antigen detection both are the combined for the early diagnosis. Viral load testing. Here the same amount of HIV RNA in the blood to monitor the disease progression and the treatment response. How much the treatment is responded and viral load decrease in the blood after the giving the treatment. Improvement in CD4 count will also see monitoring for the infection progression and treatment response. CD4 plus count T cell is the critical for assessing immune function and stages of HIV. Lower counts indicates the advanced disease and the high chance of the opportunistic infections. Further, which complicate the treatments in HIV is the drug resistance. That's why drug resistance is necessary so that we can use the better drug which are sensitive to the virus and improve the prognosis. So HIV drug resistance testing is required for the various antiretroviral drugs like NNRTIs, NRTIs, protease inhibitors, integrase inhibitors, which guide in your treatments. Co-infection screening is also required. Tuberculosis, hepatitis B and C, sexually transmitted other infections, syphilis, gonorrhea, chlamydia. TB is one of the most common co-infection during immunocompromised state. Opportunistic infection screening, depending on CD4 count, screening for cytomegalovirus, CMV infection, toxoplasmosis, cryptococcosis, pneumocystis jirovecii pneumonia may be required as the low CD4 count leads to more opportunistic infection. Basic blood test, complete blood count, CBC, LFT and RFT required to monitor side effect of ART, antiretroviral therapy, and CBC for detection of anemia, leukopenia, thrombocytopenia, may detection for the existing anemia or the side effect of certain drugs, antiretroviral like glucosamine, lipid profile and glucose, for metabolic complication from certain drugs like protease inhibitors, which leads to metabolic complication, anemia, glucosamine, effective treatment to control viral application and prevent complication. Investigation helps you for the diagnosis, management, and monitoring of HIV. Now we next move the classification of the various drugs used in the HIV. Main class of drugs. Here you see first class is the nucleoside reverse transcriptase inhibitors, which inhibits the reverse transcriptase enzyme and inhibit the pro-viral DNA formation. Drugs belong to this class is glucosamine, lamivudine, tiranosine, abacavir, stavudine, emtricitabine, and tenofovir. Next class is nucleoside, non-nucleoside reverse transcriptase inhibitors. That is not a nucleoside like nucleoside analog like adenine, guanine, cytosine. Non-nucleoside analogs. These are the nucleoside analogs, means it is the analog of certain nucleoside, analog of adenine, analog of the cytosine, analog of the thymidine, like that. It is the non-nucleoside reverse transcriptase inhibitors. Here includes the nevirapine, efavirenz, and newer drugs like delavirdine, etravirin, rilpivirine, and doravirin, first and second generation. Third class is the protease inhibitors. Drugs included or belong to this class is the ritonavir, atazanavir, indinavir, nelfinavir, sequinavir, lopinavir, and darunavir. Next class is the fusion inhibitors. Enfuvirtide, only one drug, enfuvirtide. Chemokine co-receptor inhibitors. Enfuvirtides inhibit the fusion initial steps of the viral infection. Chemokine co-receptor also inhibits the initial stage of the viral infection to the host person. Maraviro belong to this class. Post-attachment maturation inhibitors, newer drugs, ibalizumab. Remember, ibalizumab, post-attachment maturation inhibitors. This is also belongs to initial stage of viral infection. This all three drugs act on the initial stage of viral infection to the host. Next is integrase inhibitors, raltegravir and dolutegravir. Okay, this is the classification of various drugs used in the AIDS, HIV infection. Enfuvirtides, already seen, initial stage. Now we first go with the nucleoside reverse transcriptase inhibitors. First drug is the judovodin. Judovodin is the thymidine analogs. Nucleoside is the thymidine. The first and prototype NRTI is the judovodin. Judovodin converted into the phosphate after phosphorylation, judovodin triphosphate, and it inhibits the viral reverse transcriptase. Here you see the mechanism: single stranded HIV RNA via reverse transcriptase used by that virus and converted into double-stranded proviral DNA. Judovodin after phosphorylation converted into judovodin triphosphate and inhibits the viral reverse transcriptase enzyme and inhibits this step. Single-stranded to double-stranded proviral DNA cannot be formed, and further process of infection is the stop. Okay, virus reverse transcriptase integrated with the virus integrase enzyme. We already seen the process, and after that structure proteins are produced and the particles assembles and mature and then cleave off by the virus protease enzymes. We already seen the progress in various stages of the infection. Kinetics of the gidourin bioavailability is 65%, good oral absorption, quickly metabolized by hepatic glucuronidation, half-life of 1 hour and excreted in the urine 15 to 20%. It can cross the placenta and found in the breastfed milk. Adverse effect, remember anemia and neutropenia, most common side effect. No other side effect, nausea, abdomen pain, anorexia, headache, insomnia and myalgia can be there. Interaction of gidourin that the PCM azoles increase the gidourin toxicity. Azole antifungals are the enzyme inhibitors. Other myelosuppressive nephrotoxic drugs and probenecid increase the toxicity of gidourin. Probenecid reduce the excretion of the drug in the urine. Another myelosuppressive drugs like anticancers, most anticancers leads to further complicate the toxicity of the anemia and neutropenia. Now the gidourin is the less commonly used or the no longer used due to availability of the better and the safer drugs, not preferred as a first line drugs, used as a alternative and the second line drugs in the various regimens. Second drug is the lamivudine, which is the deoxycytidine analogs. It also inhibits HBV DNA polymerase. So lamivudine can be used in the HIV and hepatitis B. For the both infection, it can be used. Pharmacokinetics, it is half-life is 6 to 8 hours, longer half-life than the gidourin, and intracellular half-life is further more than 12 hours, further longer. Combination of this drug is synergized with the other NRTIs. 70% patients develop resistance to over the years in HBV infections, 1 to 5 years. So, this drug is not a first line in the chronic hepatitis infection. In resistance to the lamivudine, chronic hepatitis B, entecavir and tenofovir is preferred. Lamivudine resistant responsive to tenofovir and adofovir, but not the entecavir. Lamivudine ADR is the generally well tolerated and good safety profiles. That's why it is the one of the drug used in the first line AIDS treatment from the NACO regimens. Another side effect is the headache, fatigue, anorexia, nausea, abdomen pain, pancreatitis, and neuropathy are rare. Abacavir, it is the guanosine analog, clinically potent ARV drugs converted into carboxyl triphosphate. Same mechanism of action. Resistance develops slowly, no cross resistance, and oral bioavailability of 80%. Half-life of plasma is 1 to 1.5 hours, and intracellular it is more than 12 hours. Abacavir is the part of the first line WHO and NACO regimen in the children and patient with the impaired renal function. Dose is the 300 milligram 2 times or 600 milligram once a day. Here you have to remember is the HLA B5701 LA. When there is a presence of the HLA B5701, there is a high chances of hypersensitivity reactions. Another side effect is rash, in probable increase in myocardial infarction, nausea. Avoid alcohol during this drug intake. Next drug is a tenofovir disoproxil fumarate, adenosine monophosphate analog. This is the only drug which is the nucleotide analog. It is the one of the first line drug to be used in the HIV infection. Another drug which is active against the HPV infection. One is the lamivudine and second is this tenofovir. Both drugs are active against HPV infection. Tenofovir, lamivudine, both are part of the first line WHO NACO regimen in adults and adolescents. Most common side effect of tenofovir is this drug is the nephrotoxic, and nephrotoxicity is more severe in diabetics and hypertensive patients. So use in diabetic and hypertensive patient is you should take caution. Bone demineralization patient, osteoporosis patient, monitoring of RFT, renal function test is recommended. Drug also used in chronic hepatitis. Another drug from the tenofovir is the tenofovir alfenamide. First is the tenofovir disoproxil fumarate. Now is the tenofovir alfenamide. Difference is the only is the less toxicity on the bone and kidney compared to disoproxil fumarate. Next drug is the emtricitabine. That is the fluorinated cytidine analog. Pharmacokinetics excreted unchanged in the kidney, half-life of 10 hours, and intracellularly it is 40 hours half-life. Dose reduction is required in renal impairment patients. Pharmacodynamics that share some cross-resistance with the lamivudine. Effective against the hepatitis B viral infection like lamivudine, but cannot use in HIV and HPV co-infection because sudden stoppage leads to rebound hepatitis. In combination with tenofovir, it is used as a pre-exposure prophylaxis in high-risk adults, along with tenofovir using pre-exposure prophylaxis. Adverse drug reaction is the least toxic. Fatigue, headache, nausea, diarrhea are the side effects. Here in this table, you see the various analog of the nucleosides, means the which drug or analog of which, like a zidovudine analog of thymidine, lamivudine is analog of deoxycytidine, abacavir is analog of guanosine, tenofovir is the nucleotide analog, means there is a phosphate adenosine monophosphate analog of adenosine monophosphate. Here is the nucleoside is the adenosine, Emtricitabine is the fluorinated cytidine analog. Both is the analog of the cytidine. Emtricitabine and lamivudine. This is the deoxycytidine and this is the fluorinated cytidine. This one is the thymidine, Z and T. LC, cytidine analog, abacavir, and guanosine analog, tenofovir is nucleotide, adenosine, monophosphate analog. LC, you can remember Cl, LC, cytidine, lamivudine, ZT, butadiene, thymidine, Ag, abacavir, guanosine. Next is the non-nucleoside reverse transcriptase inhibitors divided into first and second generation. First generation includes nevirapine, efavirenz. Second generation include etravirin, rilpavirin, and doravirin. Etravirin, rilpavirin, rilpivirin, rilpivirin, and doravirin. Nevirapine, kinetic is the bioavailability more than 90%, 25-30 hours half-life. Most common side effect you remember is the rash. It is hepatotoxic and rash and hepatotoxicity is most common side effect. Dose is the 200 milligram per day. Initially, after 2 weeks, dose should be doubled. Nevirapine enzyme induces rash is the spars the palm and soles. So rash will not occur on palm and sole in 20% of patients in the first 4 to 6 weeks of therapy in 20%. So gradual dose escalation recommended over 14 days to reduce. Next drug is the efavirenz. Most common side effect is the neuropsychiatric symptoms. You should remember neuropsychiatric symptoms. Most common side effect from the nevirapine is the hepatotoxicity. From efavirenz, neuropsychiatric symptoms. Half-life is 48 hours. Metabolized by CYP2B6. WHO and NACO regimens guidelines include efavirenz as the preferred first-line regimen for pregnant and breastfeeding women because of its longer plasma half-life. So occasional missing of the doses are less damaging in the pregnant and breastfeeding woman. Dose is 600 milligram once a day on empty stomach. Second generation NNRTIs are etravirin, rilpivirine, and doravirin. Less side effects, better tolerability, effective against first generation resistant NNRTI HIV. Also effective against first generation drugs, which already we've seen nevirapine, efavirenz resistant cases of HIV, etravirin, rilpivirine, and doravirin effective in that cases. If we see both NRTI and NNRTI difference, both inhibits viral reverse transcriptase enzyme. This one is the nucleoside analogs. This is a non-nucleoside analogs. Require intracellular phosphorylation. Means pseudovodine required to convert into pseudovodine triphosphate. Nevirapine, efavirenz doesn't need that phosphorylation phase. Slow compared to NNRTI. So NNRTI Compared to NNRTI, resistance is slow in the NRTI, while in NNRTI, resistance develop rapidly. NRTI actively in both equally active in the HIV-1 and HIV-2 infection, while NNRTI is active more in HIV-1 infection compared to HIV-2. Cross resistance is also more common in the NNRTI, less common in NRTIs. NRTIs all are less common, resistant mostly more in NNRTI. Next class is the protease inhibitors. Remember this first. Protease inhibitors is the reserved drug. Now, for failed case of first line regimens. So, protease inhibitors not used as a first line drug now. All are potent CYP3 or A4 inhibitors, especially lopinavir and ritonavir are the potent CYP3 inhibitors. Most common side effect is the GIT intolerance, taste alteration, asthenia, headache, dizziness, tingling, numbness over limbs, rash. Particular concern about the side effect is the lipodystrophy, like buffalo hump, abdominal obesity, wasting of limb and face, dyslipidemia, hyperglycemia, insulin resistance, and may exacerbate diabetes. Indinavir crystallize in urine and form the stone. Stone is seen with particular of indinavir. Most common side effect you remember is the lipodystrophy with protease inhibitors, neuropsychiatric symptoms with the efavirenz, and hepatotoxicity with nevirapine. Here is the list of the drugs in the protease inhibitors. Atazanavir, most common side effect is jaundice due to inhibition of hepatic recoronary transferase inhibition. PPI reduces its absorption, half-life of 6 to 8 hours. Ritonavir, you should remember that it is used as a for the boosting the other protease inhibitors due to its high potency of inhibition of CYP3A4, low dose 100 milligram. It is not used in the nalfenavir boosting. Why? Because nalfenavir is metabolized by CYP2C19. That's why it is not used in the nalfenavir boosting. Nalfenavir is not needed for boosting, not should not be boosted by ritonavir. Lopinavir preferred protease inhibitors in pregnant women and HIV-2 infection. Darunavir 15 hours half-life, active against both HIV-1 and 2 infection. Indinavir, most common side effect is renal stone and hyperbilirubinemia. So intake of fluid should be high to prevent this. Take on empty stomach. Saquinavir, most common side effect, photosensitivity. Next class is the integrase inhibitors, one of the first line drugs now used in the HIV infection, recommended by the NACO and guidelines, WHO guidelines. First generation is raltegravir and alveltegravir. Second generation, dolutegravir and bictegravir. Raltegravir, alveltegravir, dolutegravir and bictegravir. Its efficacy is like that 95% or more than that cases show RNA copy less than 50 copy per microliter of the virus RNA end of the 24-week, 5 to 6 months approximately when integrase inhibitor is used in the combination. During the dolutegravir therapy, dose of metformin should be limited to 1 gram per day and cationic medicine should be avoided. Now this class is part of first line anti-HIV drugs in adults and adolescents, replacing the NNRTI and protease inhibitors which used previously in combination with 2 NRTI. Previously used is the 2 NRTI plus 1 NNRTI or 2 NRTI plus 1 PI. Now it is the replaced with the 2 NRTI plus 1 integrase inhibitors. INSTI stand for the integrase strand transfer inhibitors. Here you remember that gravir, if gravir is there, then that is the integrase inhibitors. Gravir, raltegravir, elbetigravic, dolutegravir, and bictegravir. Raltegravir is the first integrase inhibitor active against both HIV1 and 2. No cross tolerance with other class of anti-HIV drugs. Kinetics, orally absorbed, extensive glucuronide conjugated in liver, half-life of 12 hours. Calcium, magnesium, and other cations should be avoided. Iron supplement during integrase inhibitor therapy. Already seen. ADR, nausea, headache, diarrhea, myalgia, and skin reaction, hepatitis have occurred rarely. Dolutegravir, slow absorption, half-life of 12 hours. During the rifampicin, dose of dolutegravir should be doubled in combination with the efavirenz and etravirenz should be avoided. In case of rifampicin, which is enzyme inducer, dose of dolutegravir should be doubled. Dose of metformin should be limited to 1 gram per day during dolutegravir therapy. Cationic medicine should be avoided. Good tolerability. Side effect is mild. Headache, tiredness, weight gain, hepatotoxicity, hypersensitivity are infrequent, hepatotoxicity occasional. Next is the bictegravir, second generation integrase 10 transfer inhibitors combination with emtricitabine, tenofovir, alfenamide, and bictegravir used in India outside NACO preferred regimen. Half-life of 17 hours of bictegravir. Again, cations should be avoided. CYP3A4 mediated oxidation and glucuronide conjugation. Serum creatinine level may increase. Therapy with bictegravir. So the next class of the drug is the fusion inhibitors. Here the class is name is of the drug is the enfuviratide, which act on the transmembrane glycoprotein, which already we seen GB41. Main thing you have to remember is the fusion inhibitor enfuviratide is not effective against HIV-2 infection. There is no any cross tolerance with other class of ARV drugs. Administration route is the subcutaneous twice a day. Most common side effect is injection is the painful and may cause nodule and cyst locally. Use is Used in treatment failed and multi-drug resistant cases of HIV. Next is entry inhibitors, ibalagimab. Name is ibalagimab entry inhibitors. This one is the monoclonal antibody IgG4 monoclonal antibody. Block the entry of HIV into CD4 plus T cells by binding to CD4 receptor. We already seen entry inhibitors inhibits the entry, bind with the CD4 receptors. This one is used as a rescue medication when other drugs of the ART fail. Multi-drug resistant HIV, this drug is useful. Dose is 2 gram IV over 30 minutes followed by 800 milligram IV every 2 weeks. Initial dose is 2 gram for loading dose. Loading dose is always high compared to maintenance dose. In the most cases, so 2 gram is loading dose and 800 milligram is the maintenance dose. ADR is GIT upset, rash, lymphopenia, rise in serum creatine. This one is the monoclonal antibody, so very expensive due to their production. Next is the CCR5 receptor inhibitors, chemokine co-receptor 5, which is located on the host cell of the CD4 plus cells, and this leads to binding to the host CD4 plus T cells. Most HIV virus is the CCR5 tropic, means the virus have the affection or attraction towards the CCR5 receptor. So CCR5 tropism must be there before using this drug. If HIV is not CCR5 tropism, virus is not HIV CCR5 tropism, then this drug is not effective. Means virus is enter or bind with the other receptor rather than CCR5. There is multiple type of chemokine co-receptor. ADR generally well tolerated. Fever, cough, abdominal pain, rash, postural hypotension may be there. So the next, so what is our goals of ART is the maximally inhibit the viral replication, maximum level it is possible, and viral load in the blood became undetectable. Achieve that level. Restore the CD4 plus T cell count and immune function. लो CD4 प्लस काउंट्स को हाई करना, वायरल लोड को नेग्लिजिबल बना देना और एचआईवी रेप्लिकेशन को मिनिमल कर देना, एंड प्रिवेंट एंड हील करना अपॉर्चुनिस्टिक इन्फेक्शंस, इमरजेंस ऑफ रेजिस्टेंस को डिले करना, एंड रिस्ट्रिक्ट ट्रांसमिशन ऑफ एचआईवी. दैट इज आवर गोल ऑफ द ART. Next is the combinations which is used in the treatment of the HIV infection is the, here you see the 2 NRTI plus 1 integrase 10 transfer inhibitors. That is the preferred first line therapy by the NACO. Second alternatives are the 2 NRTI plus 1 NNRTI. 2 NRTI means Gedudin, Lamivudine, Abacavir, like that, and 1 NRTI is Nevirapine, Efavirenz, Relpivirine, Doravirine, that one. Next is 2 NRTI plus 1 protease inhibitors, Lopinavir, Ritonavir, like that. Fourth one is one NRTI plus one NNRTI and one protease inhibitor. Which one is the less preferred? Protease inhibitors is the reservoir drug. There is high metabolic side effect. You know already discussed. Therapy is known as a highly active antiretroviral therapy. HAART therapy. HAART known as HAART, highly active antiretroviral therapy. So the next is the important points. If the drug toxicity develops, the offending drug should be substituted and dose reduction should be tried first till the toxicity there, then drug should be replaced with appropriate other drugs. Institution of the ART in patients with latent or partially treated opportunistic infection may produce immune reconstitution inflammatory syndrome known as IRIS, immune reconstitution inflammatory syndrome, characterized by marked inflammatory reaction against residual organisms. Syndrome occurs due to the re-establishment of immune function. Pregnancy drugs considered safe are the Zidudin, Lamivudine, tenofovir, emtricitabine, efavirenz, and dolutegravir. Zidudin, Lamivudine, tenofovir, emtricitabine, efavirenz, and dolutegravir. Next is already discussed PIR reserve drugs avoided in metabolic disorder patients like diabetes. Diabetes it is avoided. Hyperlipidemia, dyslipidemia patient it is avoided. And therapy should not be discontinued during an acute opportunistic infection, except in case of intolerance or interaction or toxicity. Multiple drugs will be used in the HIV, like when fungal infection is there, antifungal like azoles, which is enzyme inhibitors, anti-tuberculous, when tubercular infection is there, like rifampicin, anti-toxoplasma, anti-CMV, and herpes like acyclovir, pneumocystis jirovecii like cotrimoxazole for treatment may be used. So the multiple drug use, so the drug interactions and toxicity chances is very high. Standard treatment, now we move towards according to the NACO guidelines. First line therapy is the for adults and adolescents more than 10 years, regardless of CD4 count and WHO clinical stage, age group or population subgroups. There is universal therapy, universal regimen for people living with HIV, PL-HIV, age more than 10 years and body weight more than 30 kg. Tenofovir, TDF, lamivudine 3TC 300 mg, 300 mg, both are 300 mg. Dolutegravir, DTG 50 mg. Known as a TLD regimen. TLD regimen is universal regimen used in the adult and adolescent more than 10 years, more than 30 kg, regardless of whatever the CD4 count is, whatever the clinical stage it is. Single pill once a day, fixed dose, should be taken at a fixed time every day. Next is alternative first line. When the body weight is less than 30 kg, the tenofovir is replaced with the abacavir 600 mg. All other drugs remain same, lamivudine and dolutegravir. Now patient living HIV with high serum creatinine value. So this is on the renal failure cases. Here the abacavir 600 milligram because tenofovir is nephrotoxic. Lamivudine dose as per creatinine clearance should be adjusted, and dolutegravir remain 50 milligram. So only change is tenofovir replaced with abacavir. Next is patient living HIV on rifampicin containing antituberculous therapy ATT. Here the tenofovir regimen remains same, lamivudine and dolutegravir. Just change is the dolutegravir given as a additional dose of 50 milligram after 12 hours, the regular dose. Dolutegravir should be here 100 milligram. Total dose is 100 milligram. 100 milligram should be given in the patient with the tuberculosis and continue till the completion of antitubercular therapy up to 2 weeks after completion of ATT regimen. If the antitubercular therapy is 6 months, after completion 2 weeks, 6.5 months, double dose should be continued for ART, dolutegravir mainly. Consider use rifabutin instead of rifampicin because rifabutin is the rifampicin enzyme inducer while rifabutin is not or less enzyme inducer in TB-HIV co-infection. Next is woman of childbearing potential not willing to take DTG based ART. If someone says no to the DTG, then tenofovir 300 milligram, lamivudine 300 milligram plus dolutegravir patient or person doesn't want to take, then efavirenz 600 milligram or lopinavir 200 milligram plus ritonavir boosted 50 milligram. Twice a day, lopinavir plus ritonavir. Efavirenz 600 milligram and lopinavir ritonavir. So the DTG replaced by NNRTI and protease inhibitors. Next is the first regimen we study lamivudine, tenofovir and dolutegravir TLD regimen. Tenofovir, lamivudine, dolutegravir regimen is the universal regimen. Harmonization in all adults, adolescent, pregnant women, HIV-1, HIV-2, HIV-1 and 2 infection cases, women exposed to single dose of nevirapine in the past, and those co-infected with TB or hepatitis. In all cases, this TLD regimen is the universal. Now we move towards the infants HIV treatment during their mother already positive to the HIV infection, low risk infants and high risk infants. Low risk infants are the born to the mother with suppressed viral load done at any time 32 weeks pregnancy or till the delivery. Here the viral load is less than 1000 copy per ml. High risk infant are the infant born to HIV positive mother not on the ART. Maternal viral load not done after 2 weeks of pregnancy till delivery, and maternal viral load not suppressed between 32 weeks of pregnancy till the delivery, and mother is newly identified HIV positive within 6 weeks of delivery. So for the low risk, syrup nevirapine and syrup Juduvodin, duration from birth till the 6th week of age. And when Juduvodin syrup is not available, syrup lopinavir ritonavir should be used after 14 days of the birth. 3 syrup nevirapine, Juduvodin, and syrup lopinavir ritonavir. Preferred syrup nevirapine. If not, then syrup Juduvodin. If not, then syrup lopinavir and ritonavir. High risk infants, we already covered this. Syrup nevirapine plus syrup Juduvodin here given both as a dual antiretroviral prophylaxis. Duration is the if infant on exclusive replacement feeding divided based on two scenarios, exclusive breastfeeding. If on the exclusive replacement feeding, then from birth till 6 week of age, and if on exclusive breastfeeding, then till 12 week of age. Should be the treatment should be prophylaxis for the syrup nevirapine and Juduvodin should be continued. Already discussed when the syrup Juduvodin is not available, syrup nevirapine should be used for first 14 days after birth, and after that add syrup lopinavir ritonavir till 6 weeks in case of exclusive replacement feeding or 12 weeks in case of exclusive breastfeeding. So that we already discussed more than 10 years and birth weight more than 30 kg, birth weight more than 30 kg, more than 10 years age, regimen is TLD. For the 6 to 10 years and birth weight 20 to 30 kg, the replacement is mainly tenofovir replaced with the abacavir. All other remains same. All other drugs remain same. Less than 6 years, birth weight less than 20 kg. Here the abacavir remains same, lamivudine same, and dolutegravir replaced with the lopinavir and ritonavir. Dolutegravir change to lopinavir and ritonavir. So change in the first tenofovir, change to the abacavir in 6 to 10 years, and less than 6 years, dolutegravir change to lopinavir and ritonavir. If the substitution of one ARV drug, then that means the one drug is replaced. Switch of ARV regimens, that means the whole regimen is changed. NACO recommendation 2021 for the designing second line ARTs. Here the include an integrase inhibitors, preferably dolutegravir if the failing regimen was NNRTI based. First line regimen was NNRTI based, then replace with the include an dolutegravir. Include an ritonavir boosted PI if the failed first line regimen was dolutegravir integrase single strand transferase inhibitors. Integrase strand transferase inhibitors. So if the dolutegravir is failed, then include the lopinavir ritonavir boosted PI. Protease inhibitors. Continue lamivudine of the first line regimen because it improves the viral sensitivity to other drugs. So there is no change in the lamivudine. Replace all other NRTI by new and unused NRTIs. So change one NRTI to the new and unused NRTI. Juduvodin change to the lamivudine like that. If jadivudine is used in first line, replace with the tenofovir abacavir and vice versa, like that. Here you see the regimen. Failing first line regimen is tenofovir, lamivudine, efavirenz, or nevirapine. So NRTI plus NNRTI. So recommended second line regimen if HB more than 9, then jadivudine replace the tenofovir, lamivudine remains same, and NNRTI is replaced by the dolutegravir, and tenofovir is replaced with the jadivudine. If the HB is less than 9, we cannot use the jadivudine, so it is replaced with the another NRTIs and all other dolutegravir plus atazanavir and ritonavir boosted PI, protease inhibitors and dolutegravir and existing NRTI, here the lamivudine. And in case of pregnancy and HIV-2 infection, lopinavir and ritonavir should be used in place of atazanavir and ritonavir. Jadivudine plus lamivudine plus efavirenz or nevirapine. Combined regimen if failed, then our existing regimen, first line, tenofovir, lamivudine and dolutegravir should be used. If the multiple NRTI is exposed, plus lamivudine, efavirenz or nevirapine, then dolutegravir, atazanavir, ritonavir boosted and existing NRTI backbone should be used. Second line, HAART regimen which failed containing dolutegravir. Now if our first line, tenofovir, lamivudine, dolutegravir, if failed and HB of the patient more than or equal to 9, then we replace the tenofovir with the jadivudine and dolutegravir with the atazanavir, ritonavir boosted PI, protease inhibitors and jadivudine. Then we change to the jadivudine and dolutegravir change to the atazanavir, ritonavir boosted PI. Abacavir, lamivudine and dolutegravir if failed, then change to the dolutegravir twice a day, atazanavir plus existing NRTI backbone. Here the HP less than 9, so jadivudine cannot be used. Jadivudine plus lamivudine plus dolutegravir, then it is replaced tenofovir, lamivudine plus atazanavir. Jadivudine is replaced with the tenofovir, dolutegravir is replaced with the atazanavir and ritonavir boosted. Side effect interaction, mostly we see abacavir, hypersensitivity, HLA-B 5701, rash, MI, Didenosine, dose-dependent pancreatitis, not used much nowadays, contraindicated in phenylketonuria, sensory distal neuropathy, emtricitabine, hyperpigmentation, headache, diarrhea, rash, nausea, lamivudine, drug interaction with cotrimoxazole, stauvodine, lactic acidosis and pancreatitis, Didenosine and stauvodine causes pancreatitis. Okay, here it is dose dependent pancreatitis, staurin and digoxin. Remember, tenofovir is mainly nephrotoxic acute renal failure. Monitor creatinine, probenecid increase that tenofovir level. Contraindicated with digoxin, staurin, both causes pancreatitis. Here common side effect you already seen. Jidudin, anemia, neutropenia, delaverdine, skin rash, efavirenz, neural tube defect in monkey but not in human. CNS neuropsychiatric side effect common is efavirenz. Here you see the for symptom based screening algorithm, the ART center for tuberculosis. First symptoms cough, fever, weight loss, night sweat. For children, same cough, fever, weight loss, and history with contact of TB cases. If history is yes, then investigate for TB and other disease. If TB diagnosed, then treat for tuberculosis. If not, then follow up and assess and consider isoniazid preventive therapy, IPT. Other diagnosis, give appropriate treatment and consider IPT if no contraindication. If no, then assess for contraindication to IPT. If no contraindication, then give IPT. If yes, then does not give the IPT and screen TB for regularly at each encounter with healthcare worker and during visit to health facility. For the ATD, start 2 weeks before the ART. When you start the ART and tuberculosis treatment, there is chances of iris already seen immune reconstitutional inflammatory syndrome, which can worsen the patient. Upon the if the iris develop and you stop the treatment, that can worsen the patient's prognosis. Here in the figure, you see the recommended approach to diagnose TB in PL-HIV patient living with HIV. We already seen the four symptoms: cough, fever, weight loss, and night sweat, evening sweat. Patients who are the presumptive of the tuberculosis undergo CBNet net positive for Mycobacterium tuberculosis, either rifampicin sensitive or rifampicin resistant. If rifampicin resistant is there, send the patient to district tuberculosis center or drug resistant and decide the tubercular therapy further on the sensitive based on the sensitivity of the antitubercular drugs. If rifampicin is sensitive, start ATT at the ART center and send the sample for the line probe as a inline probe as a either isoniazid sensitive or isoniazid resistant. If isoniazid resistant, send patient to the district tuberculosis center. And isoniazid sensitive, then start ATT at ART center. If the patient is NAT negative, then use the alternate diagnostic method, chest X-ray, abdominal USG. Negative NAT doesn't rule out the tuberculosis. If TB diagnosed, start ATT at ART center. If TB is ruled out, evaluate for alternate diagnosis. Okay. Next is the here the pattern with the HIV transmission from the mother to child with or without intervention, in which no ARV, no breastfeeding, 30 to 45% risk from HIV transmission, no ARV, no breastfeeding, then there is a 20 to 25% risk, short course with one ARV and breastfeeding, then 15 to 25%, with one ARV and no breastfeeding, 5 to 15% risk, two ARV and breastfeeding, 5%, three ARV with breastfeeding, 2%, three ARV with no breastfeeding, 1%. Pre-exposure prophylaxis mainly for the high-risk groups like MSM, transgender, IV drug abusers, sex workers, uninfected partner of heterosexual serodiscordant couples. Here the drug use is tenofovir and emtricitabine 300 and 200 milligram from 2 days to 28 days duration. Post-exposure prophylaxis, needle injury, particularly at the healthcare workers, nursing staff, lab technicians. Post-exposure prophylaxis used within 72 hours, preferably. For post-exposure prophylaxis, adult and adolescent, same regimen, TDL, TLD, tenofovir, lamivudine, and dolutegravir. If dolutegravir should be replaced, alternative regimen with protease inhibitors, lopinavir, ritonavir, or NNRTI if available. In the children 6 to 10 years, body weight more than 20 kg, Gidudin, lamivudine, and dolutegravir. Here tenofovir is replaced with the Gidudin, and HB less than 9, then Gidudin is replaced with the abacavir. In less than 6 years, and body weight less than 20 kg, dolutegravir replaced with the lopinavir and ritonavir, and if HB less than 9, then Gidudin is same replaced with the abacavir. Duration of treatment regimen is 4 weeks, 1 month for post-exposure prophylaxis. Here the summarization of the various opportunistic infections in the HIV and their drugs which used for their treatment. Pneumocystis jirovecii infection, cotrimoxazole, tuberculosis, antitubercular therapies, candidiasis, antifungal, fluconazole, itraconazole, voriconazole, like that, posaconazole, various azole, antifungal, cytomegalovirus, antiviral, ganciclovir, foscarnet, valganciclovir, toxoplasmosis, cotrimoxazole for prophylaxis, sulfadiazine, and pyrimethamine and ricoverine for treatment, cryptococcal meningitis, amphotericin B, and floccytosin, Mycobacterium avium complex, clarithromycin, ethambutol, and rifabutin, herpes simplex virus, acyclovir use, various malignancy, here non-Hodgkin lymphoma, Hodgkin lymphoma, cervical and anal cancer, and Kaposi. Sarcoma is associated with HIV. Recent advances in HIV is the long-acting formulations, injectables, antiretrovirals, new drug targets. Common problems seen in the HIV treatment is the resistance, adherence problem, opportunistic infection, and malignancy associated in HIV. Therefore, to prevent resistance, multi-drug therapy use switching of the drugs from Resistant drug to sensitive drugs and changing of whole regimen may be required in all drug-resistant cases. Adherence, proper counseling is required for adherence or compliance to the drugs. Opportunistic infection and malignancy add necessary drugs and the treatment modalities already discussed.